My name is Tim Byers. I'm a professor of epidemiology here in the Colorado School of Public Health and the Associate Dean for Public Health Practice. I want to say just a quick word about the Center for Public Health Practice, because it's a new center in this new school. Our center has as its purpose to do two complementary jobs: to help train the public health workforce, that is the workforce outside of the school that's working in public health, broadly defined, not just people working in public health agencies. I did turn it on. Maybe it's not loud enough? Oh, it flopped down. How's that? Is that better? Okay. But also then to work with the public health workforce to help develop projects. And project development and training really go hand in hand. So that's what our center is about. The center is going to be the organizer and the sponsoring group for these Monday seminars on the third Monday of every month. So we'll have two more this year. We'll shortly announce the topics of those. I think they're very interesting, but we haven't quite firmed up the commitment for the next one. So you'll be getting those notices shortly. But do let us know about how these seminars work for you in terms of timing, the venue, the menu, and so forth. I was just kidding in the back of the room that if we had pizza, twice as many people would come. But nonetheless, I think it's a pretty healthy lunch. What we want to do, apart from these monthly seminars, is to also feature from time to time special meetings and special seminars on topics of interest to public health in Colorado. An example of that was a day-long seminar that we held last Thursday, at a local hotel here, where we had, how many people? 50, 60 people come in from around the state to talk about Amendment 35, the constitutional amendment that raised the tobacco tax in Colorado, devoted funds for chronic disease prevention and tobacco control. Those funds have been largely taken back now because of this recession that we're in. But the meeting last week was to do some forward planning to how, when the monies come back in a year or two, and we're talking about $40 million for tobacco control and chronic disease prevention, when those monies come back, how can we strategically best use them, given everything else that's going to be happening in that era, in the area of health care improvement and public health improvement in Colorado. So from time to time we'll have special seminars. We'd be open to any suggestions that you would have. But these monthly seminars will be largely for the purpose of bringing in to the university groups and organizations and people working in public health in Colorado to share their stories with you. So I'm kicking this off. This isn't really my story. This is all of our stories about what's happening in healthcare reform and some thoughts about public health. I was sort of amused by this picture. This picture expresses the bipartisan nature of the health reform bill better than any other picture could. The only thing I'm wondering is what President Obama is thinking as he looks at this little boy next to him about. I think what he's thinking is he's wondering, are you going to have health care when you grow up? You can go to our website, publichealthpractice.org. There's a lot of information there about various kinds of trainings going on around Colorado and other fun things to look at. I include this picture now in every talk I give because it works for a lot of purposes. The point here for this talk is let's don't do the easy thing. Let's do the right thing in imagining what the future might be for an improved healthcare system and an improved system, let's call it a public health system, of assuring population health in partnership with clinical care. There's a couple issues in terms I want to get clear at the beginning. In this legislation, there are some things that are authorized to be done later, and there are other things that were specifically funded. So there's a statutory action that the bill lays out, and then there's also then authority for regulation that will come later. And in many cases, I'd say in much of the real work of and potential of public health relative to healthcare reform, most of this is still in future regulation. So just how it's going to play out, I think, depends in large part on what we from the bottom down say and do about priorities as we see them here. So my main message, I'll just say it right now, is this, that I think it's easy to imagine enormous potential for improving health through collaborative activity between public health and clinical care. If we passively sit back and don't convert that imagination into actual demonstration projects, grants, ideas, some novel approaches, and if instead we wait for the top-down ideas to come out of Congress or Secretary Sebelius or others from Washington, we will probably miss very important opportunities to improve the health here in Colorado. So the question is, what's available now versus later? Much of the public health potential stuff is for later, and that's what I'm going to be talking about. And then there's fact and opinion. The only facts I know are what I've learned through looking on the web, reading background materials in preparation for this talk. So my fact depth is pretty shallow. So what I'm going to do, instead of waiting for questions at the end, I'll have 3 or 4 times throughout the talk where a blank slide will come up, and I'm going to prompt you to share ideas or thoughts or questions that you have. But I won't hesitate to express my own opinion from time to time as to what I think we ought to do. So the Patient Protection and Affordable Care Act is largely health insurance reform. Of the 2,700 pages, I think 2,000 of them are on health insurance reform. I'm not really going to talk about that. All these issues about creating exchanges and individual mandates and how it's funded and what the limitations and regulations are in the health insurance industry, I'm not going to talk about any of that today. Clearly, a lot of that is relevant to population health, but I'm going to talk about this other stuff. The language, sometimes it's just rhetoric, I think, but I think still important intent language in there about healthcare system prevention emphasis. The idea that healthcare is not just treating disease. There's a lot of language in there about prevention and quality improvement, outcomes assessment, and population health, the kind of things that we do in public health and the kind of tools that we in population health and public health have that I think can be particularly useful for healthcare professionals and healthcare systems. I was just thinking as I was watching the students walk in here this morning, wondering where you're going to be working in the future. How many of you students have wondered that as well? Where are you going to be working? If we do this right, students now training in public health are as likely or more likely to be working in the healthcare system as in public health systems as we know them today, if we do that right. Which is not to say that you're going to be having white coats and measuring blood pressures, but that you'll be doing functions of quality assurance, outcomes assessment, and improvement of population health that are seamless and integrated into healthcare systems. There's lots of community-based prevention opportunities in the future. I'll describe those. And a lot of miscellaneous items I won't say too much about, things like workforce training, although I will touch on that. There's a tax on tanning salons, which, Lori, I saw you there, you are. So I don't think the 10% tax on tanning salons is going to be a big deal for public health, but it's in there. It didn't even make my top 10 list, I'm sorry to say, but it's there, menu labeling and so forth. So a lot of miscellaneous things. The Act created a new council of secretaries of these federal departments. Now, I don't think a council of secretaries of these federal departments is probably going to do that much. But think about it. they have to periodically sit around the table together and talk about health and prevention. So there has to be some level of communication between agriculture and HHS on school lunch and health. Transportation and HHS on transportation policy and how we're using federal gas tax for transportation design and city planning and sidewalks versus and bike paths versus roads and so forth. So it's not bad that this council exists, and I'd like to be proven wrong. I don't think it's going to be a big deal, but it provides some coordination at the top for the first time at the level of federal agencies. Clearly there's been conversation between these agencies in the past about health issues, but never before a congressionally established health council with prevention as one of its mandates at the top. I think I want to start with clinical preventive services, because even though clinical preventive services are clinical, stuff we do between providers and patients, I think they have enormous importance, and if you look historically, sort of untapped potential still for disease prevention in the population. Think about it. There's still a substantial proportion of people with hypertension in 2010 who have it not controlled for various reasons. A couple of weeks ago, I was meeting with a registered nurse on a different topic, and she just happened to mention that her husband has hypertension and he'll never go in and it's out of control and he didn't want to do anything about it. Well, you know, that's his problem. That's his doctor's problem, I suppose. I suppose that's his wife's problem, but to some extent. But it's our community's problem as well. And back in the 70s and the 80s, we had community approaches to education and motivation about hypertension control, and we just sort of dropped that. And we said, well, this is being taken care of now in the clinic. I think there's still need and potential for community hypertension control, for community weight control, for community tobacco control, and community control of a lot of different things that we regard as now as sort of routine clinical matters that we don't get engaged in enough in public health. Likewise for screenings of various types. Colorectal screening, cancer screenings of various types. So the clinical preventive services aspect of the healthcare reform bill elevates the preventive services task force to a higher level of importance than it had before. Now, unfortunately, you remember last summer when this was coming, or last spring, I guess it was. No, when was it? It was last November, actually. It was a year ago. When this was being debated, and then the whole mammography flap came out, and the Preventive Services Task Force chair, our own Ned Kalange, had to go before Congress and explain why this Preventive Services Task Force wasn't a death panel after all. Nonetheless, they came through that, and the Preventive Services Task Force grade A and B recommendations for clinical preventive services now are going to largely define what Medicare and Medicaid pay for, and by default, largely what private insurance companies pay for as well. For the first time, there's a federal law now that says tobacco cessation medication must be covered under Medicaid. There's some states that haven't been covering that. In Medicare, health risk assessments and prevention plans can now be paid for on an annual basis. What are these going to look like? Will they be wastes of time? I think those are important questions that we can probably contribute to. I don't know what these incentives are going to be. I'd be interested to know if any of you do know what form these incentives for behavioral prevention in Medicare and Medicaid might take. There's $100 million available for that next year. But what I have at the bottom there is what I think is probably the most important potential role for public health, and that is the legislation authorizes education and outreach campaigns to inform the public about what will now be universal access to grade A and B preventive services without copays and deductibles. So now the copay and deductible barrier, which for some people was a substantial barrier, will be gone. Now we're not going to get to 100% usage, but we can move a lot closer to 100% usage of effective clinical preventive services if the public health sector has involvement and messaging in the community about aspects of clinical preventive services that will play out in the clinics. I'm going to take a breath there, and that's the blank slide, and I'm going to just ask you for your thoughts at this point or ideas on anything I've touched on so far. Yes? So the question is, if we get rid of co-pays, will premiums go up? I think in the Medicare and Medicaid, they probably will not. At least they can't overtly because of this reason. But I don't know what's going to happen in private insurance. This does not regulate private insurance co-pays. Many private insurance co-pays are getting smaller. This only touches on Medicare and Medicaid co-pays. Other ideas or thoughts? Yes?
More of a question. You touched earlier on authorizes versus funded, and then in the last slide you talked about this legislation authorizes these education efforts, not funding? Yeah, so the question is on this last point about this opportunity I point out for public health to do education and advocacy in the community for the use of preventive services. The question is that funded or authorized? It's only authorized, but there's a $15 billion prevention fund, I'll talk about that later, that if it doesn't get stolen away, would be the type of money within which we could apply for resources to do that kind of education. I think the other thing we need to keep our eye on with healthcare reform from the public health side is always watch on the clinical side. See, in public health, we're used to thinking that the pie is this big, but the clinical treatment pie is as big as the room. And so we have to keep our eye on the clinical treatment side because they're going to have a lot of pressure to improve outcomes, do their job better. So any way we can work with the clinical side to help them do their job better, to get a higher proportion of smokers not to smoke, to get a higher proportion of hypertensives to be in control, then we need to look for clinical resources for that as well. I don't have a formula as to how to do that right now, but that's the kind of thing we need to keep our eye on. Back here?
Yeah, in the same token, will they limit the type of health issues that will be included with the preventive education part?
Say that again. I didn't hear all that.
Will they limit the type of health issues? Let's say, well, hypertension will be the lower priority.
Yeah, I think with regard to clinical preventive services, the priorities will be defined by the U.S. Preventive Services Task Force. And you can go online under USPSTF and see what all their grade A and B recommendations are. So it's all the usual things, you know, mammography, smoking cessation, hypertension control, cholesterol screening, a number of other things in the area of injury prevention and HIV and so forth. So there's a big list already of clinical preventive services that now for Medicare and Medicaid will have no copays attached to them. And so we should, as soon as this 2011, I think, have opportunities to go out and bump up those services out in the community. Just how we do that, you know, what channels we use, whether we use media or other community channels, I mean, that's the stuff of public health. Now, healthcare systems are going to be interested in doing that, and many of them for the first time interested in doing that, and that's where these partnerships, I think, can be helpful. One or two others? Yes?
Well, regarding the council across agencies, just as a note, Colorado does have some activities going on in children and youth across agencies, and you know, I think there's potential there. In this case, I'm thinking specifically about data sharing and data sharing across agencies, whether it's around patient care, so that when part of the system sees a juvenile whether it's justice or it's transportation or it's health or it's mental health, that they actually have full set of information on that person, and the potential for that kind of information sharing then to inform population health and local level granularity in that data. You know, I just see potential there as something.
Yeah, a good point. In case any didn't hear it, the point that this potential for data sharing across agencies, maybe not at the individual level, but certainly at the population level, data sharing about information about what's happening, that's playing out in Colorado with some cross-agency collaboration. So that could be a good benefit of this interagency dialogue and collaboration federally. Public health infrastructure. The NACHO, the National Association of City and County Health Officials, when it was announced that the monies were going to be made available, they sent a letter to Secretary Sebelius saying, send a big chunk to CDC and the rest to us, basically, to local health departments. And they're in the process of doing some of that, but there's really quite a long list of things that will be done in the future in terms of public health infrastructure. Now, you notice there's some things on this list that you wouldn't necessarily put in the category of public health. Community clinics, school-based health centers, and so forth. But all of the things on this list are going to have some of them substantially increased funding in the future. And I think all of them, if not being public health by definition, are really close to the mission that we typically have at state and local health departments. And so there's lots of opportunities for collaboration around child and adolescent health with school-based health centers that'll be expanding, nurse-managed health centers, substantial expansion of community health centers, both current ones growing and new ones coming on board with federally qualified health centers. Some local health departments will probably be establishing their own community clinics, but more likely the model will be some partnership with local public health helping in some way to establish and then make more functional community health centers. So the public health infrastructure is going to get a substantial bolus of new funding. I think the big opportunities for public health actually are in what we might see as a more clinical area of chronic disease management. Now, it used to be in the good old days, in the 40s and the 50s and the 60s, that local public health actually provided health care for the poor. And to some extent, local public health does do that on a more limited basis. Maternal and child health, STDs, tuberculosis control, immigrant health, that type of thing. Then, generally, public health kind of ran away from the clinical role. And we now have a culture, I think, for many of us in public health, where we don't want to go back there. We don't want to go back to providing clinical care again. We don't want to get sucked back into a role of being the default provider of health care for the poor. Nonetheless, I think there's going to be interesting and effective opportunities for us in public health to think and imagine what we might do in this area of chronic disease management. Call it case management, call it navigation, call it promotoras, call it all that kind of function. As a public health type business that we could develop at this interface just outside the clinic door, overlapping into the clinic. Now, in many cases, it makes more sense for clinics themselves to set this up, to hire nurse managers for diabetes, to hire their own promotoras, and so forth, and that's fine. But a lot of the work of chronic disease management is in the community. The reason why this husband of the woman I talked to, the nurse I talked to, doesn't get his blood pressure checked, I in fact don't know, but I speculate that could be remedied somehow in the community for him. So there's going to be a grant program to promote the use of community health workers. I didn't see a clear definition in the legislation as to what that is. Regulations are going to have to define that for the medically underserved. But this isn't going to be just doctors and just nurses. There's this whole medical home thing with incentives, worksite wellness programs with a grants program that's going to begin next year for small employers for worksite wellness programs. Again, think about the possibilities for wellness programs in communities that would be linked thematically and in terms of branding to other wellness programs in businesses. CDC is going to be more engaged in worksite wellness promotion and monitoring than it has in the past, so we'll probably be seeing more from CDC. And there's a home visitation program. Several of you were here, I'm sure, a couple weeks ago when David Olds talked about the nurse visitation program. He commented more on this, and that is coming down the road. I regard that as chronic disease management because a newborn has a chronic condition of life that needs to be managed. But I think at this area, even though there's very little specific language in the bill that says public health agencies shall work with health providers to provide services at this interface, I think there's enormous opportunities for public health agencies to step up and in partnership with clinical providers do a better job of chronic disease management out in the community. So there's the next blank slide. What are your thoughts? What's going through your head about any of that?
Can you speak a little bit more to the small grants for employers, small employers that worksite wellness? Is there a chance to work with public health agencies, local health agencies, in developing those kinds of things?
Yeah. So the question is, in these small grant programs for businesses for worksite wellness, is there a chance to work with public health agencies in that? Sure. Now, to the extent that we in public health just sort of sit back and watch it all happen, then it'll be less likely to happen. But this is going to happen as soon as it begins in 2011. So now is where we need to be thinking about, well, who's interested in worksite wellness in our school, in our university, in our public health agencies, state and local, and who should they be talking to start creating ideas. Now, some of these ideas are grants that we need to write before we see the RFAs. Because the RFAs have a 60-day turnaround time if you're lucky. And so we need to take the rough concepts and start creating partnerships and start sketching out what a grant would look like, what a project would look like along these lines, whether it's promotoras or any of these things I've touched on, and have those ready to go. Because if it's not the feds in 2011, maybe it'll be the feds in 2012, or maybe it'll be the Colorado Health Foundation or Rose or somebody else if the idea is really, really a good one. Others? Yeah.
And I can address Judy's comment a little bit. The health department is looking for a little seed money so that we can create a toolkit for worksite wellness and provide that toolkit to local health departments, and then those local health departments can work with their employers in their communities. So hopefully that will give them a leg up, and they'll be poised to help their local community when these grants come out.
So many of your students probably don't know who this is. Why don't you introduce yourself?
Sorry, I should have done that when I spoke. I'm Lisa Miller. I'm the acting chief medical officer. So this is my first day. Ned left on Friday.
And she's playing hooky already.
So this is my first actual day as acting CMO for the State Health Department.
Thanks, Lisa. So Lisa Miller pointing out that the State Health Department is creating a toolkit for local public health to be used to help to form some of these partnerships for cultivating worksite wellness. That's great. And then there's a conversation, and they get some things going, and then when an RFP comes out, they can apply together. Other comments? Yeah.
Well, I just had a question about what you know about the administration of these grants. Will they mostly be directly from the federal government?
Yeah, many of them. Well, they'll each come through some agency or another. CDC. A lot of them will come through CDC that have to do with public health, or HRSA. A lot of them will come through HRSA. So each will come through an agency. I don't think many will come through Sebelius's office directly, but the money gets carved out and farmed out that way. There's a big CDC RFP for some few tens of millions of dollars for public health infrastructure, and people are waiting now to hear, who was awarded and who wasn't. It's the end of the fiscal year, and we won't be seeing any more RFPs for a little while. It was kind of frantic during this year because, the legislation was passed when, in March or April? And then they had to decide at the level of the departments how much money they were going to spend, what chunk was going to go here and there. And it wasn't until July when they sort of figured out some of that stuff. And so RFPs didn't come out until quite late in the summer. So they had a 30-day turnaround time for a lot of these big multi-tens of millions of dollar grant opportunities. Hopefully next year will be a little more rational with requests for proposals and sort of word on the street about what kinds of things are going to get funded earlier in the year. Yeah.
Do you know the timeline for these grants? Because many times they only award for 2 years, and you just start the project and then it's gone. But
I think it'll vary across the different ones. We had a really uncomfortable timeline situation with the stimulus monies, which by statute had to be spent in a 2-year period. So that was, I mean, the extreme of that was the $10 million obesity grant to Tri-County that they had to spend in 2 years. So hopefully it'll be stretched out and more rational into the future. Any other comments before I move on? So there's a big emphasis in the legislation on quality improvement and improving outcomes. Now, a lot of the language is specific to health care outcomes, but it extends that language talking about health services, patient outcomes, and population health. So even in the clinical outcomes language, there's this idea that the idea is not just to improve outcomes for a set of people that walk in the door, but to improve outcomes for a population that's being served by the clinic, some of whom walk in the door. And that's kind of an important shift. And I think that's the kind of population health, public health thinking that should create, I think, some opportunities for those of us in the population health sciences to use our tools in partnership with those in the clinical sciences to assess and measure patient outcomes and population health in populations that are being served. It also establishes a community-based collaborative care network program and a nonprofit patient-oriented outcomes research institute. I don't know too much about what those are going to look like, but the important point here, I think, is a lot of talk about quality, and in the second breath after clinical quality comes population health, which is, I think, should be music to our ears. Every nonprofit hospital, beginning next year, is supposed to do a community health assessment every 3 years. And if they don't, they get fined $50,000 a year. So all of a sudden we have a benchmark for what a community health assessment is worth. It's worth $50,000. Now, isn't that interesting? Because in the Public Health Improvement Act here in Colorado, that was passed a couple years ago, public health agencies were told to do exactly the same thing. Go do community health assessments on a periodic basis. I forget how often it is. Somebody here knows. Anybody know how often local public health in Colorado is supposed to do community health assessments? Every 5? Okay. So gosh, doesn't it make sense to get together on that and do a health assessment in partnership with a hospital, and you might learn something together. So here's a natural partnership and a bit of a price tag attached to it that public health agencies and universities, for that matter, I think, should have their eye on. The law calls for improved evaluation and assessment of preventive services in the community. Again, back to the clinical preventive services thing. It specifically says we have to do a better job of assessing reach and effectiveness as to how these preventive services are impacting favorably or unfavorably the community that's being served. That's a public health function. And then finally, there's some language in there that calls for a better assessment on the reporting. It's mostly about clinical and hospital side, reporting race, ethnicity, and socioeconomic status. And here again, this is a public health function. So I think within this community health needs assessment area, there's lots of opportunity for partnerships. Any thoughts on that?
I have a question. And it's probably a very silly question. Why are they requiring the hospitals to conduct the community assessments as opposed to county health departments or
Yeah, so the question is, why are they asking the hospitals? Nonprofit hospitals have always been required to have a community benefits program, a community benefits and outreach program. I think what this is doing is it's telling them more specifically, as you think about your community benefits program, hang it on a solid hook. Do a community needs assessment. And then you can derive your benefits program from that. Because they're required, I didn't write it here, they're required not only to do the community needs assessment, but to then create a community benefits program that addresses the needs that they found in the assessment.
Well, to sort of build on Julie's point about data sharing and how effective that can be, and again, the collaboration with public health, with hospitals. If everybody needs to do community needs assessments and define different elements of the population, how good would it be to carry that in a longitudinal fashion so that it could serve both public health needs as well as hospital needs in given communities, and really build a bigger piece.
Yeah, and to do it in a way that traverses some of these boundaries, get into justice, get into transportation and other things that are health relevant, but that we usually don't think of apart from health measures.
not just across boundaries that way, but across ages?
Across what?
Ages.
Uh-huh. So the comment, for those of you who didn't hear, is not only across disciplinary boundaries, but also across ages as well. Yes?
From an economic perspective, I wonder what the rationale is behind only requiring it for the nonprofit hospitals.
I think the question is why only I thought of that too, but then it occurred to me, well, those are the ones that they can regulate, because the for-profit hospitals, they can't tell them to go do something. But the not-for-profit hospitals, if they don't do it, they get into trouble with the IRS because they're tax exempt. And so, in fact, this $50,000 fine that they will apply if they don't do it is a tax fine that the IRS will charge them a penalty for that.
Tim, a hospital can lose its nonprofit status. That's why they did it.
So Larry says the hospital can lose its nonprofit status if they misbehave in some way.
$50,000 gets lost before 7 o'clock in the morning in all hospitals.
Yeah.
That's not the teeth. The teeth is, last year you were a nonprofit hospital. You don't provide the community with a return on the investment that we're making in you by letting you be a nonprofit and foregoing tax revenue. Either you help the community or we're going to tax you. We'll take the money and then we'll come back and redistribute it, or you can take care of your community. It's really
in this area, Larry, of the community benefit requirement of nonprofit hospitals that they have to do, or they lose their tax exempt status. Let me ask you about the past as well as the future. In the past, have we in public health been sensitive enough to what that need and opportunity is? And in the future, do you think this is an area we should be looking for more collaborative work with nonprofit hospitals?
Yes and yes. Tim, I'm just loving your talk, by the way. But it's reminding me of Julia Connolly's and Carl White's book from about 30 years ago about healing the schism. And really what you're presenting here is an invitation to heal this fundamental schism between the healthcare delivery sector and the public health sector. And you're just slide after slide showing where the opportunities lie to do that. Mm-hmm. And you've really got an important message you're putting on the table here in my view. And so
you're a good student, Larry. That's good.
Using the nonprofit status thing, it's just a thing. of opportunities for the public health world and the clinical healthcare world and the information technology world to lay down the arms and imagine a different world in which instead of dividing ourselves up into pieces and having these schisms between us, we unite in behalf of good public policy and moving the dial on health status. There's just no way to have a healthy individual in a sick community.
Yeah.
It is never going to happen. So none of us can achieve what we want if we stay divided. And this bill, plus the High-Tech Act that preceded it, really is just out on the table. I don't know if any of you fish, but it's like trolling all over the lake simultaneously.
Any fishing metaphor is fine with me. That's good.
That's the thing to do right now. Do it this year. Do it between now and Christmas.
So there's a new fund, Prevention and Public Health Fund, which for the first 10 years of the fund will accrue $15 billion. It sort of starts up slowly. $500 million used to seem like a lot of money. Doesn't seem like much anymore. Builds up. And this is a public health fund then that is essentially discretionary dollars to do much of the stuff we're talking about. Not all of it. A lot of that stuff we're talking about will come from health care money. But this Prevention and Public Health Fund is very important. I think of this as the federal Amendment 35 opportunity. So in Colorado, we created a fund of money.
What happened to those dollars?
That's just it. That's my point. We created a fund, and we said, what's it for? It's for applying our current knowledge of evidence-based, effective interventions to actually do the stuff we know how to do in the community, and we're going to do it through a competitive process. The organizations and people and institutions that have the best ideas, that can make the case that they're most ready to get done what evidence-based says will actually improve health, they get the funds. And that's exactly what this fund is for. Now, Amendment 35 got pulled back. It'll come back again, but it got pulled back for a couple of years because of this great recession that we're in. The Prevention and Public Health Fund is threatened as well. There was an amendment to a small business law or bill last week that was going to gut the whole thing. Well, why is it in jeopardy? Well, because it's this undesignated $15 billion for prevention that's out there. We've got to figure out how to work with both sides of the aisle to protect this thing. Now, the problem is that to whatever extent we're seen and behave and talk like left-leaning tree huggers who want to go out there and tell people what to eat and what to put in their mouths, then we're going to lose this money. But the extent that we talk about actually saving lives and actually saving money and actually doing the important work that needs to be done so that this healthcare industry doesn't run away with all the cookies, if we can position prevention properly politically in the way we talk about it and the way we think about it, then I think we can save this fund. But it's going to be a battle every year. Every year, there's going to be efforts made to pull back the $1 billion or $2 billion that otherwise would be put into this fund on a yearly basis. So we need to think about how to protect it in terms of doing our work well, proving that we're doing our work, and also thinking politically, frankly, about how we talk about prevention and how we sell it. Yeah?
Do you know what the outcome was on that vote last week?
Yeah, it was voted down. So the amendment to kill this fund for this year was voted down, but it's going to happen every year. You can bet on it.
Where's this fund sitting and who's in charge of this fund?
It's in HHS, and so the Secretary of Health, I think that's where it is. The Secretary of Health convenes a group to decide what chunks go here and there. I'll show you right here. Here's what happened with the first $500 million. I'm not going to read it for you. You can get a sense about it. Now, right off the top, they took half of it for primary medical care training. Frank, was that a good thing or a bad thing? That was a good thing. All right. But it wasn't exactly prevention, but it was a good thing. So half of it was used in the first year for that, and the rest of it was used for this sort of litany of various things. So each year then, as we get up to bigger money, instead of 250 to spread out and spend, next year it's going to be 750, and then it's going to get up to $1 billion, then eventually $2 billion. Each year there's going to need to be a priority setting process whereby we make decisions, and this is largely going to be at the Secretary for Health, I think, decisions about how to allocate these monies. This is, again, where we need good ideas and good effective input from people. Yes?
What's the definition of primary medical care training?
What was that? How was that defined?
The short answer is training more and more diversified primary care clinicians, family physicians, general internists, general pediatricians, general nurse clinicians.
Basically, what they want to do is they want to try to beef up the workforce so that in 2014, I need to move on, so that in 2014, we have enough primary care docs to deal with the Medicaid expansion. Yeah.
So still no money for preventive medicine residency, which
Nope.
is the only one not.
Preventive medicine residencies were not specifically increased. There's some community transformation grants. I'm going to finish up in 5 minutes here, so hold on with me. Community transformation grants, these came out of this prevention fund that I just mentioned. And this is essentially, I think, where this federal version of the Amendment 35 is going to be. Competitive grants for evidence-based programs to implement and evaluate them, focus on health disparities. They mentioned a national diabetes prevention program, but they didn't specifically fund it. I think that'll come out of probably next year's money. This could be a very big deal, and this is what we need. There was a weak start on this in 2010, but I think it's going to be much stronger next year. There is some stuff on public health workforce training, some loan forgiveness that students in schools of public health will be eligible for. I think, though, that the biggest opportunity for public health training is in our getting engaged in training in the healthcare workforce. So we've got to broaden our thinking of who's doing the work of public health, and I think it's largely going to be in what we're now thinking of as the healthcare sector. We did last week receive some of this money from this prevention fund here in Colorado. The Colorado Public Health Training Center, one of 33 such centers. This is where they are. Seems to be an overconcentration in the east, but we're used to that out here. Our center just covers the state of Colorado. I think eventually we'll probably take in some of the surrounding states and create a regional center with our renewal in 5 years. This center is within our Center for Public Health Practice because this is one of our missions to do workforce training. And basically, we'll have a future seminar at some point giving more details. But our approach is highly collaborative, working with a number of different organizations and individuals to provide training across Colorado of the public health workshop. So here's my top 10 opportunities. Number 10. National Prevention and this Health Council. So I made my list, but it was only number 10. Menu labeling. I actually think that's kind of cool. That made my list, even though I didn't talk about it here. Workforce training. If we can train the public health and the healthcare workforce to work at this interface, we got a great opportunity in workforce training to make the world a better place. Oh, I got to say, in our HRSA grant, our logic model actually ended up with make the world a better place. I don't think they actually read that, but they funded it. So. Quality improvement that includes population health. So clinical quality improvement, population health quality improvement, enormous opportunity for us in public health. The support to community clinics is going to make things a lot better out there for people that we serve in public health. great opportunities for promoting clinical preventive services in the community, doing community health assessments in partnership. Chronic disease management actually is pretty high on my list. I think if we can finally figure out how to work together to do things that we knew worked in 1960, that would be great, and we can do it in the community. These community transformation grants, I think, are going to have enormous opportunities, $2 billion a year, if we can protect the Prevention and Public Health Fund. But we got to do the right thing and not the easy thing. And I think my time's almost up, except for a comment or two. Yeah.
Well, this comment, I guess, is on the amendment $35. And actually, when you said that, I was thinking, I hope that's not what happens, because I kind of feel like the amendment $35 had fed a dysfunctional system. When you see local people competing for these monies in a system where they have no chance for continuity over time, you know, the system doesn't support a lot of these.
So there's a bad aspect to competition, and you're pointing it out. So the question is then, as we put out these monies from this fund in the future, how do we make this right balance between competition and collaboration, and between short-term projects and long sustainability infrastructure type stuff?
And just realizing the way that things have run before is so many competitive funding to local communities that don't hang together, and all the administration that goes around that.
I noticed under your first plan that there were other public health centers.
Yeah, in the school. The MAP ERC, Rocky Mountain Prevention Center, Cayenne, and so forth. We'll be working. Because most or all of the other, including Global Health, the other centers in the school, Latino Research and Policy Center, have some aspect of workforce training and capacity development in their own missions. One more comment, and then we'll stop.
Where do people go in terms of keeping up with the policy message that's going to be used as far as protecting the prevention fund and advocacy? Has that started to organize so that people can keep track of it and weigh in when
I don't have a good website for you, but well, it's important enough that we should kind of keep our eye on that, and we'll from time to time be saying some things about it on our publichealthpractice.org website, so that might be a good place to keep up on anything. And thanks to Jan for the spell check at the last minute. She found cubichealthpractice.org. It's the same thing, sort of, but not exactly. Thanks, everybody.
Yes.